Hello, this is Clerk Karen May Bernizo presenting glaucoma. So, what is glaucoma? It is an acquired chronic optic neuropathy characterized by optic disc cupping and visual field loss. It is usually associated with raised intraocular pressure. There are different types of glaucoma, and according to etiology, we have primary glaucoma, congenital glaucoma, secondary glaucoma, and absolute glaucoma. According to mechanism of intraocular pressure rise, we have open angle glaucoma and angle closure glaucoma. The major mechanism of visual loss in glaucoma is retinal ganglion cell apoptosis. This leads to thinning of the inner nuclear and nerve fiber layers of the retina. Axonal loss in the optic nerve. The optic disc becomes atrophic with enlargement of the optic cup. For the acute angle closure glaucoma, the intraocular pressure reaches 60 to 80 millimeters mercury, leading to acute ischemic changes to iris with associated corneal edema and optic nerve damage. For primary open-angle glaucoma, the intraocular pressure rises above 30 millimeters mercury. The retinal ganglion cell damage develops over years. For normal tension glaucoma, the retinal ganglion cells may be susceptible to damage from intraocular pressure in the normal range, or the major mechanism of damage may be optic nerve head ischemia. To diagnose glaucoma, we have to do history taking and do patient evaluation. For history taking, we have to take note of the onset of visual loss, whether there's bilateral or unilateral visual loss, any changes in vision, or the need for eyeglasses. You have to ask for other ocular symptoms in order to rule in and rule out other conditions. Ask for the past ocular history, including surgery, trauma, and concomitant eye disease. Ask for the past ocular history, including trauma, surgery, and other concomitant eye disease. Ask for the past medical history, including comorbidities and current medications and allergies. Ask for the family medical history, though it's not usually contributory, it is an important factor when treating normal pressure glaucoma. For primary angle glaucoma, it's usually slow and painless. For angle closure glaucoma, there's sudden onset of visual loss. Then for patient evaluation, a comprehensive eye exam is usually done, so the visual acuity is assessed to see if there is change in vision. Refraction is assessed to determine the refractive state. In glaucoma, there is increase with increasing myopia. There is also the slit lamp exam, tonometry that measures the intraocular pressure using the Goldmann applanation tonometer, gonioscopy that allows direct visualization of the angle structures, including the anterior chamber angle width. Then we have to do the optic nerve head evaluation to examine the optic nerve for damage and obtain photograph of the optic nerve. Visual field testing is essential to diagnose and follow up of glaucoma. It assesses peripheral vision and the most used is the Humphrey perimeter. The visual field loss are detected when there is approximately 40% retinal ganglion loss. For the management of glaucoma, there is medical therapy and surgical and laser treatment. To treat for the raised intraocular pressure, we usually use the medical therapy. To facilitate the aqueous outflow, prostaglandin analogs are usually the first-line therapy. This includes latanoprost, bimatoprost, and they increase the scleral outflow of the aqueous. To suppress the aqueous production, Topical beta-adrenergic blockers are used, such as the betaxolol, carteolol, and timolol. However, this is contraindicated for those with chronic obstructive disease, including asthma and cardiac conduction defects. Brimonidine is an alpha-adrenergic agonist. It inhibits the aqueous production and secondarily aqueous outflow. Dorzolamide and brinzolamide are topical carbonic anhydrase inhibitors, and acetazolamide, a systemic carbonic anhydrase inhibitor, are also used to suppress the aqueous production. To reduce the vitreous volume, hyperosmotic agents are used. Examples are the oral glycerin or glycerol, isosorbide, and mannitol. They, they can reduce the vitreous volume by making the blood hypertonic. As a result, it draws out water from the vitreous. For surgical and laser treatment, there is peripheral iridotomy, iridectomy, and iridoplasty. They allow direct communication between the anterior and posterior chambers that removes the pressure between them. There is also laser trabeculoplasty, which applies laser burns via gonulens to the trabecular meshwork to facilitate the aqueous outflow. There is also glaucoma drainage surgery, such as the trabeculectomy, which is the most used to bypass the normal drainage channels, allowing direct access from the anterior chamber to subconjunctival and orbital tissues. So this ends our discussion. Thank you.